is a huge honor for me today to be podcast interviewing Brad Eli, DMD, MS, all the way from San Diego, California. Brad is an orofacial pain specialist with offices in San Diego. He is a diplomat of the American Board of Orofacial Pain and diplomat of the American Academy of Sleep Medicine, American Academy of Dental Sleep Medicine. He has medical dental appointments at 6 regional hospitals in Southern California and is an expert witness. His referral network includes physicians, cardiologists, pulmonologists, ENT physicians, oral surgeons, endodontists, periodontists, and general dentists. He is recognized by medical and dental experts for success with complex cases. Dr. Eli has managed his pain center for over 25 years using a multi-disciplinary protocol to treat acute and chronic pain and headache patients. Refined techniques include appliance therapy, behavior modification, psychology, physical medicine, and anesthesiology. He also has managed a sleep practice for over 25 years, offering all non-surgical therapies for sleep disordered breathing. Treatment is based on disease management model involving recall and retesting, resulting in high rates of compliance with prescribed treatment, including CPAP and other oral appliance therapy. He obtained his DMD from Temple University in 1987. That's in Boston, right?
Philadelphia.
Oh, Philadelphia, okay. And graduated in UCLA's inaugural postdoctoral orofacial pain training program with a master's in oral biology in 1992. He's a pilot and he likes to invent things to solve problems. And I called you, you did not call me, because you're the founder of Splint, correct?
That is correct.
Quicksprint.com, and when I saw that, I said, I'm going to find out who's behind this and see if you come on my show, and you did, and I thank you for that.
Well, thanks for having us.
So tell us, so I don't know, I want to start with the basics. You're talking to lots of dentists in 150 countries. Why don't you just start with, first of all, what is an orofacial pain specialist?
Well, in 1990, the people at UCLA were running a TMJ center. And what they were being referred is a bunch of patients who had complex facial pain conditions. They had seen a number of physicians in ENT, neurology, rheumatology, and they were then being sent to the TMJ clinic because nobody could figure out what was wrong with them. They would come to the TMJ clinic, and the TMJ experts at the time, Bill Solberg, Glenn Clark, these are, Terry Tanaka kind of people, said, you don't have a TMJ problem, so what do we do with you now? So the people there at UCLA put together a program. Jim Frickton, Bernadette Yeager, Stephen Graff Radford, God bless his soul, and others put together a program that was a 2-year postdoctoral fellowship in orofacial pain. What they decided is there was a need. There was a group of people who were falling clearly between the fields of medicine and dentistry, and there was really no one to take care of them. So I was in the first of the classes. There was a training program that occurred 25 years ago, and since completing it, I've practiced and limited my practice to orofacial pain. And as of 2 years ago, we now are a recognized specialty, and we market ourselves as that, and are able to say in the field that that's what we specialize in. So
now, is that recognized by the American Dental Association, or?
Well, interesting that, I don't want to get too far off topic, but I guess it's an important topic to raise. The American Dental Association is a trade organization, and as a trade organization, they ran into a little difficulty with the implantology group.
In Texas.
Because there was some implantology or providers, oral surgeons, or people who had done 2-year postgraduate programs in implantology who were limiting their practice to just implantology, just like I had limited my practice to orofacial pain, temporomandibular disorders, and sleep treatment for the past 20 plus years. So a couple of years ago, I got on the phone with the general counsel at the ADA, and I said, the population doesn't understand the word limited to. What they understand is the word specialist. So when you follow the rules or the law that of the land and you say limited to, and then you have a bunch of family dental centers who say specialize in TMD, and they, see one patient a month and put the same treatment in everybody, it was a little bit off. So the state of California has officially retired and said that if you limit your practice to doing just that, then you are not improperly or false advertising, and they're not gonna argue about it anymore. So as of last year, I'm an ADA member, I'm a CDA member, and I'm a San Diego Dental Society member. And my listing in the San Diego Dental Society book says specializes in TMD, orofacial pain, and sleep disorder treatment.
And I'm a Amazon Prime member and a Costco Club holder.
There you go.
I have both of those credentials in my wallet.
Exactly.
Well, that's just fantastic. So you're absolutely a pioneer.
Well, absolutely, and I enjoyed it. My first 10 years of practice was in the anesthesia department of university hospitals, and when I interviewed with the physicians who ran those hospital pain centers, once I described who I took care of, they said, "When can you start? We have a number of those patients and we don't know what to do with them." And so that became the start, and the rest is, I guess, history, as they say.
So what did you want to talk about today? I wanted to get you on and talk about the quick splint. Because, I read basically you're an orofacial pain specialist and you see patients who had no history of prior injury but had an acute sudden onset of jaw pain, and left untreated for more than 4 weeks, their condition progressed to what you call delayed recovery. Can you talk about that?
Absolutely. This entire field, being a new field and especially a new specialty, like any other specialty, it has to start defining, stratifying, and assisting the general practitioner in how to take care of the simple cases, get at them early. What I was finding is patients were being referred to me. It was taking them 4 to 6 to 8 weeks to get to me, when something simple that would have been easy to give by the general dentist would have resolved the problem, and I would have never had to even see them. The whole point of a specialty, Howard, is to take care of the people that have to be seen by a specialist. And, that is the hallmark of a true specialist, is someone who doesn't want to see everybody. Someone, a periodontist who's worth their weight in anything is going to go to the generalist in the community, and they're going to say, look, gingivitis, local pocketing, this is how I want you to take care of that. Take care of that early so the patient doesn't have to come and see me. There's plenty of patients for people like myself, but right now we're being inundated by people who should be treated by people who are in their general practice and not scared off because they have a simple jaw onset. So we are going through a bunch of different programs right now. We're trying to set up, the quick splint was a simple, easy to use method. I termed it to myself the ace bandage for the jaw. So everyone knows how to treat an acute sprain injury of the ankle. Well, you wrap it up and you ice it, and that's because the orthopedic surgeons said, look, we don't need to see a person with an acute ankle sprain. You can wrap it up with an ace bandage, you can put some ice on it, you can not walk on it, and then if that doesn't clear it up, then you send them to us. And so that's what I really wanted to communicate to the Dentaltown people, is that, there's a lot of people who really want to back away from the TMD patient. I was reading one of your message boards, And, the title was, I Could Give a Flip About TMD and Here's Why. Was this, and I wrote a note to myself to make sure and have a good explanation as to the 12 jurors as to why you have that opinion, because when you get sued, that doesn't come across very well. So you can simply and easily intervene with a simple, easy process. You can interfere with the onset early. And as you mentioned in the intro, within 4 weeks is the magic time. You have to get acute symptoms under control within that 4-week period, or that symptom is likely to be present in 80% of the population 5 years later. That's a big number. And chronic pain is a big dollar number. And so that's the basis for the whole quick splint theory. And it's the basis for why we want quick splint to be available and utilized by your population.
So you talk about the JAMSS protocol.
Yep.
What do you phonetically say JAMS protocol or
JAMS?
JAMS. Okay, JAMS protocol.
So JAMS stands for jaw and muscle sprain strain. So a typical patient who would fall under that category would have the diagnosis of a muscle sprain strain or a jaw joint sprain strain injury.
It stood for jaw and muscle soreness sprain?
Sprain strain.
Sprain strain.
Yeah. So
can you say that 3 times really fast?
Not on a webinar. So the issue is that there is a number of things that we are not taught in dental school about the jaw and the jaw joint system that are key. Number one, that if a patient has a hypermobility syndrome in their jaw and they're asked by a practitioner to open wide, they can theoretically put their jaw right next to a point in which it can be injured. Now, as we're taught in dental school, to support our working hand with a finger rest on the lower jaw, you can then extend beyond a safe range of motion and create a muscle sprain strain injury. This is a patient who will call the office the next day and say, I woke up with a very stiff jaw. I couldn't open my mouth. I have a lot of pain. And as I recall, when I went through dental school, there wasn't a class in what you were supposed to tell that person. So we fumble along and we say, well, that take some ibuprofen and, eat soft foods and, it should clear up. But realistically, since no specialty existed in the field, there was no defined protocol. JAMS gives the general dentist a defined protocol. It says clearly, if a person calls after a procedure and they have a complaint of limited jaw opening, muscle pain, or joint pain, we want that patient to be brought back into the office. We believe that that patient should be paid attention to, that is, re-examine what's going on, get a, quote, starting point of where the disorder is present at that moment. And then by instituting anti-inflammatories, soft chew diet, and something that will interfere with nighttime behavior, you can oftentimes clear these things up, and then they just go away. And there's going to be a lot of your listeners who are going to say, well, I've never done that before and I've never had to do that. Well, I can tell you that it only takes one patient to ruin your history in that concept. And as time goes on And as our protocols become more and more known, it's going to be more and more difficult to defend dentists who say, oh, well, it usually cleared up, so I didn't do anything about it. And when you can do something, there's nothing better in building a strong relationship with a patient than when they think they have a problem, you think they have a problem, and you want to take care of it. So we are very, very pro interacting with a patient in need.
Well, but why do you think I assume, a filling must be so much easier to do a filling than anything to do with TMJ, TMD, orofacial pain, because it seems like most dentists agree on a filling protocol or an endodontic protocol. If you got 100 endodontists together, there's almost no passionate arguments. But my God, when you go into TMD, TMJ, orofacial pain, it's like 20 religious groups all trying to agree on something.
And I appreciate that. And before I went through my postgraduate training, I attended 5 different religions. And at the end of it, I realized that there certainly is a higher power. But, if you ask any specialist, they'll tell you the same thing. If you don't know what you don't know, then it's easy to follow a path. And what I learned in postgraduate training, just like most every other specialty training program, is why. So I describe it as the difference between a baker and a chef. Okay? A baker can make a very nice cake, but a chef knows how to modify to make that cake the way it needs to be made for that particular individual. So this is all about keeping a patient out of that level of problem, interacting early intervention. So if a person calls with a complaint, these are not chronic complaints that we're talking about. This is, yesterday you gave me a mandibular block, you prepped 3 teeth on my lower left, I can't open this morning and I'm in severe pain. That patient needs to be seen. That patient needs to have their opening measured at that time. That patient needs to be given specific instructions on what to do to deal with that, and therefore resolving that problem when it's still an acute pain problem. So this is not about a TMJ, do it this way, that way, or the other. This is all about acute intervention by the general dentist in anywhere USA and the world, frankly, and taking care of their patients when their patients need to be taken care of. Scaling and root planing with anesthesia, scaling and root planing without anesthesia. So, like you said, the endodontists will all agree that there's a certain protocol. Well, one of the protocols that the endodontists have brought back to us is the fact that this device is so simple and easy that when they have a diagnostic question, is it a muscle problem or is it a tooth problem, by discluding with the quick splint, they can take that and differentiate that a little easier. We've had the same thing with implantology. So I made it for the TMD field to try and eliminate chronic pain conditions. And now what we found is that a lot of people within the field have started to use it for various other uses and had good success with it.
And one of my very good buddies has a review on your website, quicksplint.com, John Nosty, who I just adore. He says, QuickSplint is great as a temporary appliance prior to getting an orthotic fabricated, as a deprogrammer, as a night guard to go over Invisalign trays, as a temporary night guard over your veneer temps or reconstruction cases, and as a temporary appliance over your newly seated cosmetic or reconstructed cases. That's quite an endorsement.
Well, we have been very lucky. Every single person who takes the time to look at this product says pretty much the same thing, and that is, well, this is genius. And, you know, another person who I know you know well, Lee Brady, I was watching a video on her hand making an anterior bite plane, and it took her about 20 minutes. The quick splint takes about 2 minutes, and it's placed by your staff.
So Leanne Brady on your site says destruction of the dentition from grinding and clenching is a significant problem for patients and dentists alike. Often the amount of damage will necessitate complex restorative dentistry to restore the teeth. For early recognition and treatment of potential parafunction, I have found Quick Splint to be a convenient and easy anterior bite plane design that can be applied on a trial basis to patients almost universally. Yeah, we both live in Phoenix. She lives upstream. And you have another one that I did a podcast interview with, my endodontist friend from California, Scott Weed, an amazing endodontist, says the Quick Splint is an essential tool of my practice. It is an effective and easy way to provide short-term mechanical protection to certain teeth. It is also very effective in aiding my diagnosis of various pain conditions. So tell him, how does your assistant do? How is it made? How first of all, how much is it? I assume they order it at quicksplint.com. How much is it? Do they order it at quicksplint.com? How much is it? How's it made? Go through the protocol.
Okay, so it's a preformed tray that has retention characteristics built into it, so it does not require any adhesives. It costs $20 a unit, and a fast set, heavy body bite registration or something similar to that is overloaded into the tray. You can see in the back right here one that's done. It's overloaded into the tray. Then the patient actually bites it into place, so it levels it against the upper and lower arch. And then the excess is trimmed off, and the patient is sent home with the device in a little pill bottle looking thing like this. So from this to this done going home is done in our office by me saying, Justin, who's my assistant, please make this person a quick splint, and I walk out, and they walk out of the room about 5 minutes later.
Nice. I mean,
and it is purposefully transitional. So the other thing, as an expert in this field, that I'm not a huge fan of is partial coverage devices used long term. So
like a NITI, an NTI,
just any partial coverage device. So
you just don't want to say NTI.
Well, no, I'll say NTI. I know Jim Boyd well. As a matter of fact, you know, I'm on his thank you page of his little handout. So Jim Boyd had a very, very good idea. And the idea that he had was to get something in a person's mouth and make it easy. So, you know, the good parts about it was quick and easy. The bad parts are hard, long-term, and partial coverage. So we just went through and, you know, I guess I just made a better NTI.
So basically that's it. Because basically, explain more to kids that if you use an NTI long-term, you're saying that posterior teeth will super erupt or change occlusion?
Well, there has been plenty of cases that have been seen through the years where there's been changes. The posterior eruption theory, I'm not a big believer on. I don't think that part-time use of a partial coverage device is likely to cause posterior eruption. However, when you have an anterior point contact, the one thing that you're counting on is that the entire system works correctly. So your teeth work, your PDLs work, and your jaw jerk or jaw opening reflex is intact. So what I have seen is with people who use NTIs only long term, the two teeth that they actually strike have a tendency to flare or move.
I enjoyed reading your article in JADA. It was in the August 17, 2016 issue, Preventing Chronic Pain After Acute Jaw Sprain or Strain. How did that, you want to talk about that article?
Sure, that was our inaugural article in this whole process. So I came up with this device specifically for myself. I had the form made and had placed 1,000 of these in patients in my office before anyone even approached me, or I even thought about making it available to the other dentists in the country and in the world. And what really motivated me to do that is the fact that I was seeing too many people who could have been easily treated by their general dentist or prevented from excessive tooth wear or a device that would assist with that never-ending argument of do they grind their teeth or not. So, the hygiene department says, we're concerned that you may be grinding your teeth. The patient swears they don't grind their teeth. Well, put a quick splint in, see the patient 4 weeks later. Trust me, you will be shocked at how much wear you will see on the surface of this device in that 4-week period if the person is a grinder. And that has eliminated that I grind, I don't grind issue with many patients. So that's how general dentistry uses it. They use it to protect their work. When people temporize anterior veneers, every single day between the placement of the temporary and then the placement of the finals is a nail biter, so to speak, because those things pop off. And so at least you could take the pressure off of it by using that.
So on Twitter, you're at QuickSplint. I just retweeted your tweet today where you basically received, you were talking about how you received Dental Industry Recognition Award. Orofacial Therapeutics announced today that its premier product, QuickSplint, has received 2 recent industry recognitions. QuickSplint was recognized as Reader's Choice Top 25 First Impression Products by Dentistry Today magazine, and it was named a 2016 Clinical Problem Solver by the Dental Advisor. That's impressive. So do you work much with the Dental Advisor, or how did they call you, or did you send them samples, or how did that happen?
Most of the things that we've done so far have been people in the field. Once they see the product, they say, this is fascinating. It's so simple that everybody says the same thing as, why didn't I think of this? And
that's actually the opposite of dentists, though. I mean, it seems like if you go to a study club, one guy will stand up and say, "Hey, I just want to let everybody know that I trim my own dies." Yeah. And then the next one will stand up and say, "I just want everybody to know that I quarry pour my own stone and trim my own dies." And the next guy's like, "Well, I quarry my own stone. I have my own beehive. I grow my own wax. I pour." I mean, it seems like they always want to make a mountain out of a molehill. So I would say you're the swimming against the stream. If you try to make anything faster, easier, lower cost, simpler, it's almost like it's anti the religion of dentistry. It needs to be really, really hard and complex, or the dentists don't even believe it.
I think that you are right, and that, I think, would define the old school type of mentality. I think we have a whole new group of providers who look at dentistry as a way to come to work, do good work, feel good about taking care of people, but they're not living it like the old guard. And
that's a really nice way to say millennials are lazy. Did I just hear that right?
No, I think that they're intelligent. I think that they realize that there's more to life than sitting in an office and whittling on things.
Well, that's what we see it around the world. Birth rates have gone down. I mean, they've gone from 1945 in America is 5.2. Now it's under 2.3. Japan's under zero point 0.9. When I lectured in Japan, those female dentists were telling me that most of them said, who would want to bring a kid into the life if it was going to live the life of their father, who just basically
Right.
worked all day, every day, 7 days a week till he dropped dead?
Right.
And you're right. So they're going to be smarter. Podcasters are generally younger people. Older guys our age, they read JADA. The millennials probably don't even know what that means. That stands for the Journal of the American Dental Association, and I've had the honor to be published in that 4 times. And but the bottom line is questions they're asking. They're asking some specific questions. I'm going to throw a laundry list at you and just have you die. They say things like, how come the greatest guru of occlusion, Peter Dawson, says that it's all teeth and has no TMJ, TMD? It's all the teeth. It's not the brain. It's not stress or anything like that. Another one that they have a very pointed question is they want to learn more about TMD after school, and they see there's kind of like 2 camps. One's a neuromuscular camp, and one's more a CR camp, like Pankey, Dawson, Coy, Spear, and they're wondering about those. So let me throw those 2 questions at you.
All right. Well,
and then the third question is, well, if it's all teeth, like Peter Dawson says it is, then why do 80% of the TMD patients, why are they female? So there's 3 questions. My questions are so bad, I throw 3 of them out there and see if you can grab any of them's worth answering.
Okay, so let me start with your question regarding occlusion. Occlusion is an important variable that we do have some input and control over. However, it is difficult to explain how occlusion is a cause or a direct recovery source when orthodontic patients spend 2 years in chronic malocclusion that changes every month, and very few of them become symptomatic.
Exactly. And what percent of the TMJ experts on the circuit for the last 50 years never did a single orthodontic case?
Okay, well, so the issue is, and that comes full circle back to 5 religions versus understanding that religion is religion. So when you have a group of people and you are trying to give them information in a period of time and they want to go back and make a difference, you can't teach them to be a chef. You can only teach them how to bake a cake. So the issue is after I went to 5 different cake schools, I knew that there was more to it than a single cake. The issue really that I think is the easiest way for us to agree, and John Nasty and Mike and I went and we were golfing one day, and it was myself and one of my other colleagues who had graduated from our postgrad. And at the end of the day, we said the same thing, that we're orofacial pain specialists. Temporomandibular disorders is only one small group within a broad spectrum of orofacial pain. And honestly, they probably should be separated. So if you have chronic pain following the 5th endodontic procedure on the same tooth, it rarely responds to splint therapy or occlusal equilibration. At the same time, if you are going to reconstruct the entire mouth, then I think it's very important to know occlusal principles and put the occlusion into a reliable, reproducible position. So we agree that there is a place to do things and to do things correctly. And really, where they run into trouble is when they try to fix a square hole with a round peg, or a round peg in a square hole. So occlusion is an important piece of the system in which we rely on to chew and to maintain our weight. If a person has a occlusal problem, especially if they have an occlusal problem in which there's a hyperocclusion, there's no doubt in anybody's mind what tooth is hitting harder than the other, because it is insanely painful. And if you understand the neuromuscular system and the neurovascular system and the stomatognathtic system from the chef's perspective, then you can see how all the parts fit, and you can agree with certain parts of the Dawson approach, the Coyce approach. They all have a place, but you can't universally put them in every camp and expect it to answer every single thing. So I think they do a great job of teaching how to make a specific cake, so to speak. And the only problem is then if the person is allergic to flour and you don't know how to bake a cake without flour, then you're pretty screwed. And so is that patient, because that cake is usually a pretty expensive cake. Now, the second thing that you asked me was,
why is 80% of it women?
Two reasons, and we do have good literature and good support on this. Number one, women are more likely to come and seek help for a problem. Number two, they're more available to seek help for a problem. So, you're open 8 to 5, they're available 8 to 5 if they're, a non-working person. And the third thing is that women have a different pain threshold than men. We also know that women's entire neuromuscular system and joint system go through changes when they become pregnant. Obviously, their entire pelvis and all of their ligaments soften. We all know this. We were taught all this stuff. We just conveniently forget that there's a big difference between men and women, other than one's from Mars and one's from Venus, I think.
Yeah, wasn't that a joke? That book. I mean, wasn't the guy who wrote "Men Are From Mars, Women Are From Venus"? Wasn't he divorced like 5 times?
Yeah, I think he grew up on Uranus.
Huh. You know what? I would especially these millennials, they much prefer online CE over these courses.
Right.
We put up about 350 online courses. They've been viewed basically 2/3 of a million times. I mean, it's crazy.
Yeah.
I wish you would. Could I ever talk you into making an online CE course for Dental Town?
Sure, I'd love to do that. The more people who know how to make something simple and easy, know how to make simple, easy diagnostic decisions early in care, is going to make them an asset to their community, an asset to their practice, and save them a lot of heartache.
Well, what's amazing is these millennials. I've had several of them show it to me. You take your iPhone and you hold it in front of your big screen TV, and you pull it in, and you realize that not very close, you can't even see the big screen TV. They actually watch online CE on their iPhone or their iPad, whereas you and I always went to the annual convention. Very
Right.
popular. But there's two. The Greeks said that there was two great emotions, fear and greed. So the greed is what you're talking about right now. Let's make this faster, easier, lower cost, cheaper, better. The fear, though, is getting sued, and you're an expert witness. Share some stories about being an expert witness. And number one, what's that like? Is that stressful, being in front of a jury and the judge and all that stuff? What's that like? Share some stories.
Well, so being an expert is being asked to have an opinion and to, I'm sure you've done this work before, but it's being asked to determine whether or not a colleague has met a standard of care. So if a person, for instance, were to call an office and say, I have this terrible jaw pain, you did a procedure on me yesterday, and then I read from Dental Town, I could give a flip about TMD and here's why, I think that that is going to be someone who I'm going to be on the side of the patient saying, well, you should give a flip because it would have cost you 15 minutes, only 5 of which was doctor time. You wouldn't have had to break down an entire room to put one of these things in, and you could have had a 80% chance of resolving the symptom within 24 to 48 to 72 hours. So that is a hard argument to go down on the side of a practitioner. Being in front of 12 jurors is an opportunity to see a system that is very, very, very compromised when it comes to professionals. So it's hard to explain to 12 non-dentists dentistry. It is also very hard to explain to 12 non-dentists why the dentist didn't take 5 or 10 minutes to just do something. So there was a case, I remember I was in a case once where an oral surgeon prided himself in getting a tooth out in 5 minutes. And when the patient called with a problem, he didn't see him. And a week later, he called again and he didn't see him again. And at the end of the day, what really stuck in the juror's head is, if it takes you 5 minutes to get paid to take them out, why wouldn't you take 5 minutes to pay attention to the problem? So, it really comes down to, are you trying to help? Are you trying to be a professional when you need to be a professional? So if a person put a quick splint in, let's say, so you had a patient yesterday, you did a mandibular block on them, you had them open for 45 minutes, you had to use a bite block or an isolite or whatever, and they call the next day and they say, I'm having difficulty opening and I have some pain. You have whatever protocol that you have, but that protocol was developed not by an expert in the field, such as myself, but it was developed from your just understanding of what you've done all those years. Now, what we're trying to do is we're saying there's a specialty in this field. As a specialist, I have a responsibility to try to help those new practitioners and the older practitioners and the seasoned practitioners who are interested in doing what they can do to, with ease, intervene early. Early intervention, we call it speed to treat. If I can never see your patient because they never become long-term symptomatic, that is the best ever. Okay? Stratification of patients, maintaining patient health is critical to our future and is what we have a responsibility to do.
Do you ever mix the quick splint with pharmacology?
Absolutely.
What specifically?
So
I'm Irish. We just hand them a bottle of Jameson and 30 Percocet. Am I doing it right?
Well, if you want to hand them the card for a liver transplant specialist as well, yes, I think you got it perfect. Typically, what you want to do is you want to try to understand the etiology behind the symptom. So a muscle sprain strain doesn't necessarily involve inflammatory mediators. So a pain pill or a muscle relaxant would probably be the most appropriate care, along with something to interfere with nighttime guarding. So what happens is if a patient is in pain, when they are sleeping, they will put their teeth together and they will hold their teeth together in a guarded position. That's a natural tendency to pain. Patients in the daytime, you've been in your operatory and you're looking at a patient and you can see their masseter just firing right in front of your face, and you say, I'm concerned that you're clenching, and they say, oh no, I don't do that. And you're looking at them and saying, yeah, you do. I just watched you do it. Well, if you have an injury, if that injury is muscle-based, then pain medication, muscle relaxants, soft chew diet, heat, and or ice. So early ice and then heat, and alternating will get the blood flow increasing and the healing going in the correct direction. If you have inflammatory disorders, then you want to add an anti-inflammatory of some sort. And Advil is a fine tool. You just have to take it every 4 hours.
You and I have been doing this. We both graduated from dental school in '87, and when I got out of school in '87, it seems like the first 10 years, the press was filled with all these stories that patients were dying of cancer and not getting narcotics and not getting pain, and these stick in the mud physicians and dentists. He pulled my wisdom teeth and gave me Tylenol. So there was this big push to write prescriptions for opioids.
Right.
Now, 25 years later, now the pendulum swung all the way to the other side. Now they're like, you doctors prescribe too many opioids, and now 30,000 Americans a year are over to. Well, you're talking to a lot of kids right now. They're 25, they're 30. What are your thoughts on opioids? Is there when do you prescribe or think opioids are a good choice, and or do you think they're way overused?
Well, I think there was a period of time where opioids became overused, but in a pain practice such as mine, it's going to be a lot different. So in a general practice, my recommendation would be, if you assume a person is going to have a painful condition, then make the assumption that you know how long that painful condition is going to be. You and I both know that the 3 days following an extraction are the worst 3 days. So give an appropriate dose for 3 days. Don't give 100. Okay, so I think that where we ran into trouble is this, here's 50 pills, here's 100 pills, and people became their own pharmacies. And so that's really where the problem lies. I'm fascinated by the numbers that the CDC uses in their, we have a crisis. Last year, 400,000 people died of smoking-related illness, and I don't see the CDC stamping out tobacco products today. So, it's an easy target. I think dentists have gotten caught up in it because we do prescribe a lot of narcotics, but we do it in a short-term period. So I think it's an appropriate drug. I think that it's appropriate to prescribe it for the duration of your expected pain. And then if the person gets that, let's say 10 pills, and they have pain beyond that 10 pill period of time, they need to come back in and see you. If you give them 50, then by the time you see them again, they've had a dry socket, they didn't respond, right? So you don't want to give them so much medicine that they're able to not act appropriately.
I want to switch gears completely to sleep, obstructive sleep apnea. There are some dentists out in dental towns saying that anybody who grinds their teeth, every one of them, has to be evaluated for sleep apnea, because it's a sleep apnea that's causing so much night grinding, and that it's standard of care to get a sleep study. And when someone's grinding their teeth, you and I know that out in the field, the average dentist is going to take an impression and make a night guard. That's
Right.
standard protocol. Now, some people are saying, no, you cannot do that. What if it was from sleep apnea, and then the guy dies in the middle of the night with a heart attack because you didn't do your job? You just made him an upper, mouth guard. Rant on that.
Well, there is definitely some information that shows that there is some correlation between airway protection and nighttime behavior known as sleep bruxism. But what you're doing now is you're proving that the field of orofacial pain and the field of sleep treatment is more than a weekend course. So the guys who, put on a weekend course and say everyone who grinds should be tested for obstructive sleep apnea, I would say the 12-year-old girl who's, 50 pounds, you're going to test her for sleep apnea. I don't think that's probably reasonable. Number two, if you are the determiner of who's tested and who's not tested, and then you are the determiner of the most appropriate treatment, then I will be the first to tell you that you will have difficulty defending your position if a sleep physician were to actually say, just let's review what part of your education, training, and practice would support you having enough expertise to make this level of call. So I think it's an important thing to know about. I think there is some correlation between it, but the whole idea that it's standard of care, you and I both know that what that term means, and that means what the majority of practitioners in a geographic region would do in a similar situation, and it's certainly not standard of care at this moment. It is the care choice by the people who have facilitated the ability to do it. And so they are validating probably excessive testing, just like we see a little bit of excessive testing with CBCT scanning these days, making claims to predict airway and airway effects of sleep treatment. As you can imagine, I have a little bit greater depth of understanding of this disorder than most, and so I don't want to overwhelm your listeners with a bunch of rhetoric, but the reality is that I think I mentioned it in a recent article. If a physician heard about a soft tissue program and wanted to integrate it, how much training do you think it would take a physician with no dental education whatsoever to institute a soft tissue protocol or soft tissue program for the gingiva in their practice? You and I both know they're licensed to do it. They could put somebody in their office, an assistant. So how many hours of training would you want them to have in order to do a soft tissue program? Well, that's what I say to dentists who are dabbling in sleep medicine. Dental sleep medicine is a bit of a misnomer. Dentistry has a place. The place is to make sure that the oral cavity can tolerate and is stable enough to be anchored upon when and if the patient's choice would be an oral appliance or a mandibular advancing device. But other than that, it's a lot of training, and it is a lot of time, and you have to be pretty committed.
So what is it about San Diego and TMJ? The Terry Tanaka is also from San Diego.
Well, it's 72 degrees and sunny.
Does he still practice?
He no longer practices. No, he's still doing some, I think, education, but he no longer practices.
Do you ever see him or talk to him?
Yeah, we talk every once in a while. About every year, we'll kind of touch base with one another.
I still laugh every time I hear his name, because the first time I ever heard a TMJ lecture, he was showing this is 1987. he was showing slides from his office of just human heads in the pano machine, just a head. And the
Right.
person next to me almost, when he saw it, he like screamed, and then
Right.
he about passed out. And I'll never forget Terry talking about how his dissections were the best because his heads weren't soaked in formaldehyde. They're
Yeah.
formaldehyde-free heads.
Right.
And I
right.
was sitting there in 1987. Oh my God, this guy is intense. This guy is intense.
He really, really, really did a great service for the anatomy. Henry Gramillion has picked it up and continued it quite a bit. They do a head dissection every year at the AAOP meeting. And so, if anybody's really, really interested in the detail like that, they can do that.
And what meeting is that?
The American Academy of Orofacial Pain has a yearly scientific meeting, and they will usually have a breakout session, which is a human head dissection.
Now, is Jim Boyd, is he out in California too?
Yep, absolutely.
Where's Jim at?
He lives in San Diego as well.
Oh my God, so is that right? So
Yeah.
how have you talked to Jim?
I haven't talked to Jim in a while. I think I saw him about 2 or 3 years ago at a meeting and said hello, and he's a good guy. I like him a lot.
Yeah, his lecture, there's more passion in a Jim Boyd lecture than just about anything you're ever going to hear. He talks 8,000 mile words a minute. I mean, his presentation has to be exhausting because he's so animated. But hey, thank you for responding to my invitation. I found this to be very interesting. This is Dentistry Uncensored. I like to talk about the things that not everyone agrees on. I mean, I don't want to have shows where people say, yeah, I know all of that. Oral facial pain, TMJ, TMD. This is where the ball is for so much. I really hope you make an online CE course to show your orofacial pain background. It's a very common question on the message boards, as you know.
Yeah. Well, there's a couple of things that I want to make sure that you know. The AAOP meeting is in Scottsdale this year, so you may want to stop by. Maybe you could get a head, little head dissection. And
is Terry Tanaka going to be there?
Terry won't, or at least I don't think so. But Henry usually runs that. And then also we want to let all of the listeners know that if they'll go to our website, we're happy to give them a little sample starter kit, and they'll get a little bit of a benefit from getting used to this. We also...
And that website is slowsplint.com?
No.
Oh, Quick Splint.
Quick Splint.
I thought it was Slow Splint.
No, it's quick.
It's quick, okay. But see, now they'll remember it.
Even you can make it quick. No, the key is really to let your staff do this. This is very, very, very staff driven, and it is very easy for the staff to do, and it doesn't take doctor time, and it shouldn't take doctor time. We're also, just like the JAMS protocol that we put together and the concept of speed to treat, we're going to be working on a thing called the SAFE protocol, which will try to help risk assess patients so we can maybe offset some of the problems that we see that way as well.
Okay. Well, Dr. Eli, thank you so much for your time. Thank you so much for coming on my show. I'm sure my homies appreciated it. And we look forward to hearing more from you in the future.
Alrighty. Thanks, Howard.
All right. Have a great weekend playing golf.
All right. I will.
You're going to go out there and hit some balls today?
I'll probably lose $20 tomorrow.
All right. Have a great weekend.
All right. See you.